Thank you for coming. I'm Dr. Wang. I'm the clinical neurophysiology fellowship director. It's my pleasure to introduce today's speaker, Dr. Grant Turek. Many of you know Grant well, and he went to his medical school of Loyola University in Chicago, and after that he had a residency in child neurology here at the University Louisville. He will graduate in June and already take an excellent job offer in Ohio. He's a very busy man, very extraordinary resume. In addition to his busy residency and fellowship, Grant also participated in many research and published articles. He also received several scholarships and awards. Without further ado, please join me in welcoming Grant, please.
All right. Good morning, everyone. I'll go ahead and get started as people continue to trickle in. I have no disclosures. And today, our objectives, I would like to review the concept of semiology, something that I find personally very interesting, and I hope you agree. With this, we will look at the idea of seizure symptomatic zones and review what literature can tell us about neuroanatomical localization of a seizure onset zone. Historically, as I will allude to later, these were determined by scalpel electrodes, but now with the adoption of invasive neuromonitoring techniques, our understanding of ictal foci deep to the scalp is advancing. And with those objectives in mind, it's my hope that we gain an appreciation of the complexity of neuroanatomic localization and the tool that semiology can be for surgical intervention for refractory epilepsy patients. To understand seizure semiology, we really need to appreciate its roots. The word itself hails back to Greek times, the word semion meaning a sign, mark, or token, but it's developed quite a bit since then. Sometime later, this gentleman, Ferdinand de Saussure, grew a mustache and started thinking about society. He coined the terms semiotics and semiology in the late 19th century, but that's not really quite what we mean in neurology when we talk about it. In his work, he used this term to describe the study of signs or events as they pertain to life on a societal level, and how daily interactions lead to the development of language tying together past, what's come before, and new innovations. His contemporary, the acknowledged father of pragmatism, American philosopher Charles Peirce, described a sign as anything which is so determined by something else, and so determines an effect upon a person. I.e., I see that the person ahead of me that's driving has turned on their blinker. I am affected in a way that I now expect them to move in that direction. The sign being the, of course, signal determined by that other driver has an effect upon me. So as we move from this brief touch on philosophy, let's keep in mind the fundamental component of pragmatism. For any statement to be meaningful, it must have a practical, and in our case, clinical bearing. In 1964, in an effort to unify the vast variety of seizures under descriptive terms, Henry Gustav, with the aid of the International League Against Epilepsy, tried to create a unified description of seizure activity so that epileptologists could continue to study and communicate effectively. Then, near the advent of the video EEG in 1981, epileptologist Fritz Dreyfus and his associates created much of the naming structure we currently use. Further modifications have been made through the last 40 years, and semiology, its use for seizure description, and the utility of a unified naming structure were recently recertified as being important to the practice and continuation of the study, as recently as 2017, via the International League Against Epilepsy's publication of their seizure classification system, and subsequent amendments encouraging neurologists, epileptologists, and lay staff to use this terminology and allow for accurate communication of seizure manifestations, onset, and spread. For the purposes of our discussion today, I'd like us to keep in mind seizure semiology is defined as the manifestation of abnormal activation of the symptomogenic zone, However, if you talk to several epileptologists or neurologists, you might find slight variations of this definition. To understand onset zones and symptomogenic zones as it relates to epilepsy, this is a brain. In the case where, there we go. In the case where a symptomogenic zone is in the anterior temporal lobe, it used to be thought that the seizure onset zone would be included in that same structural space where the green represents the symptomogenic zone and red represents the onset zone. But back in 1966, thanks to the work of Turek and his associates, as well as subsequent studies, we know that the irritative zone, or the zone that generates interictal spikes, seizure onset zone, and symptomogenic zones do not necessarily need to all be connected or share the same structural space, though they do need to share the same brain. This thought opens up the idea of epilepsy and seizures to be a disorder of neural networks and allows the epileptologist or neurologist to begin to think of treatments on a network level rather than just local to the symptomogenic zone. That is to say, were you to pursue resection of just the region of symptomatic expression, one might disrupt a seizure network, but miss the location of the pathology that is acting as a seizure generator or onset zone or irritative zone leading to continued seizure potential. This brings up the interesting concept of the human connectome and how diffusion tensor imaging can be used to evaluate network connections within the brain and aid in planning of epilepsy surgeries, particularly where brains are immature, have previous white matter lesions, or if there's a concern for a focal cortical dysplasia. For example, I had a recent patient who we were going through cortical mapping, we were stimulating various areas, and she had two superficial cortical areas where we stimulated, and both, despite being regionally separate, would stimulate the same seizure pathology. Interestingly enough, if you looked at her diffusion tensor imaging, we went back and processed all the information, it was found that those two anatomic locations, even though they were distant anatomically, actually shared a white matter tract underneath. So recognizing that these zones of influence and the connections between various areas of the brain can have similar networks, I want to show you the ILAE 2017 naming criteria. From the 2017 naming manual, we see that clinical descriptions of seizures, and if you followed me this far, we know that these clinical symptoms that patients experience that we see in the clinical setting, be it the emergency room, EMU, or out in the world, these clinical symptoms described by the ILAE are expressions of activation of a patient's symptomogenic zone, which may or may not be anatomically similar to the onset zone. What the patients experience are symptomatic signs of an abnormal neural network activation, i.e., those signs being semiology. For our talk today, even though you can see that you have generalized onset, unknown onset, I'd really like to focus in on the focal onset. Because I'd like to focus in on the focal onset because if you're talking about semiology and localization, if you have a generalized onset, there's really no purpose. There are false localizing signs that can occur in generalized epilepsies, but really the value comes from focal epilepsies. And you would not expect to define the seizure generator of a generalized epilepsy further. The first qualifier in describing focal seizures that the ILAE encourages is whether awareness, not consciousness, is preserved. Consciousness is harder to define and to test for after the fact of a seizure, whereas one's awareness of self or surroundings can be documented and clinically determined. You are probably all familiar with our EMU personnel reminding people to remember blue skies or think of purple elephants, and this isn't just them trying to soothe patients out of having a seizure, but rather a way of documenting their awareness of their surrounding at onset. A focal aware seizure is one where a patient can recall events and surroundings that occur throughout the duration. So we would then go back and be like, what phrase did you hear? Did you hear remember purple elephants, remember blue skies, etc.? The presence or absence of awareness in a patient's seizure gives us localizing benefit. In 2002, using video EEG and electrocorticography, Lux and his colleagues evaluated impaired awareness and found it was most commonly associated with either bitemporal or left temporal seizure activity, and was less commonly seen in frontal and parietal lobe seizures. In contrast to that, in 2020, a group led by Dr. H. Wong found that groups with insulo-opercular seizures often have awareness preserved. Even the length of a focal aware seizure can be beneficial, given that seizures originating from mesial temporal lobe are longer in duration than those of neocortical extratemporal origin. The mesial temporal lobe here being made up of the 5 structures: the hippocampus in light blue, the perirhinal cortex in yellow, amygdala in purple, entorhinal cortex in dark blue, and the perihippocampal cortex in green. After awareness, the second major descriptive modifier is motor versus non-motor. So let's talk a little bit more about motor onset. Got a video here. Let's make sure it works. So as you can see, she is kind of fumbling with her hand here, pulling at her shirt. And automatisms are defined as repetitive, non-rhythmic movements that most often involve the hands or orobuccal region. Video to scroll on. And I think you all get the point. Okay. So previously, automatisms have been associated with temporal lobe seizure onset, and we're not changing that, but we're expanding upon it. More recent studies have expanded this to show that activation of the insulo-operculum, frontal convexity there in orange, the insulo-operculum in blue, temporal lobe in green, the supplemental motor area in yellow, and the orbitofrontal region can all be seizure generators that initiate automatisms. Proximal movements, such as bicycling of the legs or arms, typically occurs from the frontal lobe, whether it's the frontal convexity or the orbitofrontal region. These automatisms tend to be shorter in duration while being faster in frequency. Alternatively, seizures that occur from the supplemental motor area, temporal lobe, or insula tend to be longer in duration and occur at a slower frequency. And these ones often have more lateralizing potential because they are often unilateral. As far as other lateralizing signs in automatisms go, preservation of awareness, as we said previously, is a strong indicator of non-dominant mesial temporal lobe onset. But if awareness is not preserved, suspicion would be more towards the dominant side. Let's take a brief look at atonic seizures. So this young boy is laying on the couch, and atonic seizures can be a little bit difficult to see if somebody's laying down, but you can see that he does this head nod every once in a while, and eventually he'll get up for us, and we'll see that he does have a little more body maintaining his body tone. Atonic seizures are defined as when a seizure leads to complete loss of a tone of the body or extremities. Here we go. There we go. I wanted you all to see that atonic spell before we moved on. All right. So atonic spells, atonic seizures, generally have the perspective of being a generalized onset. However, this talk isn't meant to evaluate the semiology of generalized seizures, but I feel like it should be mentioned since that is the most often etiology. However, there is such a thing as focal atonia. In the instance of focal atonia, such as that impacts the trunk, it has been shown that frontal and temporal lobes are more implicated than other structures. But then in the instance of extremity atonia, it could be originating from the primary motor cortex or the mesial frontal region, or the area anterior to the supplementary motor area called the negative motor area. Activation of the negative motor area leads to suppression of activity, typically occurring contralaterally, i.e. meaning that if the right side is atonic, then it will likely be coming from the left side of the aforementioned area. Let's have a look at some clonic seizures. So per the study by Vendreme and his associates in 2011, among the patient population afflicted by clonic seizures, about 2/3 are focal in onset. Clonic seizures defined as rhythmic stereotyped muscle contractions, as we see here in this infant. When focal, the symptomogenic zone is usually contralateral primary motor strip. The typical evolution of the semiology includes distal clonus with Jacksonian march, usually with contralateral head version away from the side of ictal activity. Motor activation, likely due to motor activation of the contralateral sternocleidomastoid muscle, followed by a postictal paresis. Preservation of awareness at the onset of clonus suggests an epileptogenic focus in close proximity to the motor strip rather than the motor strip itself. Depth electrode and cortical stimulation studies have found that clonic seizures can be elicited from areas in the temporal lobe and the insular opercular lobe, again, these being contralateral to the symptoms and ipsilateral to the area of ictal onset. Then moving down the classification system, just going right in order, we have epileptic spasms, which are characterized by abrupt onset, flexion, extension, or mixed flexion extension of the proximal and truncal muscles, lasting 1 to 2 seconds. However, more subtle forms are documented with only facial or eye movements or head nodding. Let's see if we can see a few more of them. There we go. Right. While these types of seizures can be due to generalized dysfunction, it is also possible for focal lesions in any of the lobes to be an exacerbating factor. Some studies suggest that as many as 40 to 60% of epileptic spasm patients may arise from focal lesions. And those of you who were present at Dr. Burr's grand rounds last week, we know that though they may have an underlying genetic or metabolic condition such as tuberous sclerosis or another epileptic condition, that does not preclude them from having a therapeutic surgical intervention. When these seizures are focal in origin, they most commonly are due to lesions in the frontal lobes. And in order of subsequent frequency, we see lesions arising from the temporal, parietal, occipital, and finally the insular lobe, least likely but still possible. Oh, sorry. There's the sound. So hyperkinetic seizures. Complex violent movements of the trunk and proximal segments of limbs that include multiple planes of articulation. This could be seen as pedaling, swimming, or even bizarre movements such as writhing or pelvic thrusting. She has quite a few of these kind of hyperkinetic truncal movements here, and I want you to see the best of all of them. Now, the adage that I've kind of learned through our my time here at the University of Louisville is that generally these types of seizures tend to be due to a deep focus. Whenever there's a question of like, well, is this more of a odd psychiatric behavior versus potential seizure activity, we always talk about, well, is there a focus deep to the scalp electrodes where the electrodes can't seem to reach and get a good enough signal because there's just so much tissue and other electrical signal in the way. So people would always take a very close look at those frontal leads, seeing if there was anything that might clue them into this being a potential epileptic seizure coming from the orbitofrontal region. However, with frontal onset, there is but with other potential onset zones, we can kind of elaborate on some other potential clues as to where these seizures could be coming from. So with frontal onset, there is often associated emotional facial expression, such as fear or laughing or anger, without the patient actually experiencing that emotion, which becomes important later. Or motor features such as bilateral elbow flexion, bilateral forceful grasping, facial flushing, and bilateral facial contraction, kind of like a grimace, have all been associated with hyperkinetic seizures of frontal onset. Now, if we're talking about hyperkinetic seizures of temporal onset, those are more frequently associated with oral alimentary automatisms, more often to occur during wakefulness, have been associated with salivation, and bilateral dropping of the corners of the mouth. Now, nocturnal hyperkinetic seizures may also arise from the insulo-opercular regions, as described in a series of 8 patients. The complex motor manifestations occurred with seizure spread to frontomesial regions, as well as neocortical temporal lobe, but were generated in the insula. And of note, in hyperkinetic seizures, if that is what you are classifying your patient to have, and are trying to localize it, unfortunately, neither non-versive head turning or body turning or asymmetry of limb movement have any lateralizing value. Taking a break from human patients, this is a furry friend with myoclonic epilepsy. Myoclonic seizures being muscle contractions lasting less than 100 milliseconds, as seen in our friend here. I think they're going to have another. There we go. So these muscle jerks may be whole body or confined to the face, trunk, or to one or more extremities, as we saw in our furry friend. Traditionally considered a generalized seizure type, they can actually be focal in origin. Multiple studies implicate the superior frontal cortex, which includes the primary motor cortex, the premotor cortex, and the supplementary motor area as potential areas of seizure onset. Although it is worth mentioning that in one case series, they showed improvement in myoclonus with other focal resections of the temporal lobe and parietal lobe. But they didn't have enough information to really make a unifying theory about why that was. Tonic seizures consist of sustained muscle contractions that last for several seconds, preferentially affecting proximal muscle groups, can be unilateral, bilateral, symmetric, or asymmetric. 23% of tonic seizures have been shown to have a clear focal onset in a video EEG study of 225 pediatric patients. Most focal tonic seizures arise from the frontal lobes, usually precentral and premotor regions, but they can also arise from the parieto-occipital and less commonly the temporal lobe. VERSIVE seizures are a subset of tonic seizures. They consist of involuntary, sustained, forceful turning of the head, eyes, and trunk away from midline. often associated with neck extension, resulting in a sustained unnatural position. This must be differentiated clinically from non-versive head turning, which resembles natural movements and is not a reliable lateralizing sign. A little anecdote about versive versus non-versive head turning. Recently, Dr. Caracas and I were doing mapping on a patient as recently as 2 days ago, and she had one area that we stimulated on her right frontal cortex that caused her to consistently just kind of scan the room to her left, looking for her girlfriend, who wasn't present at the time. And she knew between stimulations that her girlfriend was not in the room. But every time we stimulated that part of her frontal cortex, she would have non-versive head turning. Compare that to when we actually triggered her seizure, and she would have non-versive head turning to the right, followed by some very versive head turning to the left and dystonic posturing of the neck. Versive seizures, they can be the initial manifestation of frontal lobe seizures, in which case the symptomogenic zone may be the contralateral prefrontal eye fields. Versive seizures are also can be associated with speech arrest, and it's actually been seen that Broca's area could be involved, if not the seizure generator in those cases. It is important to note that version can be a false lateralizing sign, particularly in genetic generalized epilepsies such as JME. You'll have the patient having these unilateral tonic posturings, but all it is the JME expression. In contrast, focal seizures progressing to bilateral tonic seizures often involve a sequence of version, tonic pulling of the face and arm, or tonic pulling of the face to the contralateral side. They assume the fencer position with the arm extended and the ipsilateral arm elevated. And then this is followed by asymmetric tonic posturing to the figure 4 position. And this sequence usually lateralizes to the contralateral, this type of seizure progression consistently lateralizes to the contralateral brain from the extended arm. So that's a lot about motor. Let's talk briefly about some non-motor onsets. So, autonomic seizures are labeled as such when their predominant feature involves objective autonomic manifestations such as tachycardia, retching, and emesis, though any number of symptoms have been reported. Sympathetic and cardiovascular phenomenon tend to be the most prominent. These types of seizures were found to be primarily associated with mesiotemporal lobe and amygdalar onset, but also had areas in the insula, mesial prefrontal cortex, and as implicated for seizure onset zones. Interestingly enough, a seizure of the anterior cingulate, denoted here in pink, is seizure of the anterior cingulate, noted here in pink, is consistently associated with hypersalivation as a autonomic feature. And this seizure is an absence seizure, which is, of course, as you all know, a generalized type of seizure onset, but I want you to pay attention to the semiology it has, because that's the semiology I'd like to describe here. Seizures of behavioral arrest, formerly called dialeptic or hypomotor seizures, are defined by the prominent feature of having impaired motor or awareness. We'll see as this young boy continues to do his homework, kind of has impaired interaction with his surroundings. Then comes right back to it. Typical of an absence seizure, but again, it's the semiology that I want you to focus on. Okay. So, seizures of behavioral arrest. 3 separate video EEG studies found that adults and children with this type of seizure tend to have foci, when it is focal, in the temporal or parietal lobes, though a 4th study did find that frontal lobes were the predominant causing factor. So we have, with this, 3 studies telling us that, temporal and parietal lobe are typically the onset zones. And this is just with behavioral arrest. If we read that 4th study that said that frontal lobes predominate, They allowed their hypermotor seizures or behavioral arrest seizures to have automatisms associated with them, whereas the other two did not. And if we recall automatisms from earlier in the presentation, there was quite a bit of frontal lobe representation when studied with depth electrodes. Not necessarily critiquing that one study that was that fourth study that was different than the other three, but more pointing out that, well, if we have automatisms, that kind of changes where we're pointing to, and that would technically be classified as a motor onset seizure. Now, cognitive seizures are characterized by transient alterations in thinking and higher cortical functions that are focused and prominent in comparison to other relatively unimpaired aspects of cognition. These can be negatives, such as aphasia, anomia, alexia, or positives, such as forced thoughts and déjà vu, the sense that something has already been experienced, and even hallucinations. One thing that is particularly hard about déjà vu is having a patient describe it. Again, in the clinical setting, there was a patient that she's like, oh, I'm having my déjà vu feeling, but it's only a little, and my déjà vu feeling, but it's a lot. And we were trying to discern how that related to her typical quote-unquote aura, which we determined through depth electrode was actually her smaller seizure that didn't generalize. But having somebody describe this, like, oh, well, I'm very familiar with the sense that this has happened before, it is very hard to articulate. So having a little bit of narrative exploration as how they experience that is always a good idea to further pin down exactly what they're feeling. Interestingly enough, when we were doing mapping on this patient, we innervated the posterior cingulate, and that actually caused her to have that déjà vu sensation consistently. Cortical stimulation studies have found that the mesial temporal lobe, lateral temporal lobe, and insula are often implicated in cognitive seizures. Déjà vu has been reported in seizures arising from the anterior cingulate, and dysarthria, language dysfunction, have been reported in association with insular stimulation. Take a look at some dialeptic seizure, or not dialeptic. So emotional seizures. Emotional feelings, the feeling of prominent emotions such as fear, happiness, or anger, or the state of appearing as though affected by such emotions are termed emotional seizures. Well-known examples of this are gelastic and dichristic seizures associated with hypothalamic hamartomas. Our patient seen here is having this repetitive, forceful laughing, and I turned the audio off, but what you can hear in the background is mom trying to figure out what the patient's laughing at, trying to get her attention to break her out of this cycle of laughter, but she's unable to really rouse the patient. She just continues to have this forced laughing. Now, emotional seizures tend to originate from the temporal lobe and amygdala, though emotional seizures characterized by anxiety and fear have been reported to be arising from the anterior cingulate. So if your predominant feature is anxiety or fear, you're thinking like more the anterior cingulate structures. If the feeling that the patient is expressing or is seen to be expressing is more rage, then you're thinking more the anterior or ventral aspect of the insular region. Intense fear with frightened facial expressions, screaming, and agitation are characteristic of seizures, of emotional seizures that arise from the medial prefrontal cortex. And moving right along, there's actually the somatosensory seizures, which has all of its own categories. There are auditory seizures, which can consist of simple auditory hallucinations described as buzzing or ringing. Complex auditory phenomenon, such as hearing voices or tunes, have also been reported. Now, the type of auditory phenomenon can help us localize a little more as well. Buzzing or ringing has been associated with seizures in the superior temporal gyrus, specifically Heschel's gyrus. And then auditory sensations are reported on intracranial EEG studies of the insula, and more complex auditory perceptions, such as hearing voices or tunes, tend to be through activation of the temporal association cortex rather than the insula or Heschel's gyrus. Patients are usually unable to lateralize these sounds, and unfortunately, if they do lateralize to the patient's left or patient's right when they hear them, they aren't reliable lateralizing signs. It could be on the left or the right, and you could be hearing the sound on the left. Gustatory seizures may present with metallic or blood-like tastes that may be difficult to characterize for patients. Again, having that instance where the patient just can't come up with the right word because nothing else is really like what they're experiencing. Typically, gustatory seizures have potential onset zones suggested in the temporal lobe and frontal lobes. However, in the instance of unpleasant pharyngeal sensations going along with them, this points more, unpleasant visceral sensations and somatosensory or motor signs coming along with the gustatory sensation. This is more likely to have an insular seizure onset zone. So really exploring that history, going step by step what the patient can relate to you can help you localize a little further, rather than just saying like, oh, well, they have an abnormal taste. Well, they have an abnormal taste, they have a lump in their throat, and then their body tingles. That's like, oh, well, that might point us more towards the insula. Olfactory sensations, typically unpleasant scents, described as sometimes sulfur or burning rubber, hence the picture. Though one patient recently described it to me as saline. Olfactory seizures such as this can typically be seen in seizures originating from mesial temporal lobe, but have also been seen in association with neoplasms involving the amygdala or orbital frontal portion of the gyrus rectus, which the gyrus rectus denoted here in yellow is that medial medial curvature of the frontal lobe. Olfactory symptoms have also been reported in association with some insular epilepsies as well. Focal somatosensory seizures, or auras, occur in about 12% of patients with focal epilepsy. Tingling being the most common sensation and most commonly described auras, there's also potential for sensations of pain, electrical shocks, thermal changes, and sensations of movement or pulling that have been reported. Discrete distal unilateral sensations are most common and implicate the contralateral primary somatosensory cortex. Bilateral extremity or axial auras suggest involvement of secondary somatosensory cortex. Secondary somatosensory cortex, which is actually the portion of the cortex inferior to the primary somatosensory cortex in the operculum on the parietal lobe, highlighted here in pink. Somatosensory illusions, such as sensations of shrinking or swelling, movement of body parts, can be elicited from non-dominant inferior parietal lobe or temporal parietal occipital lobe junction with stimulation studies. And an intracranial EEG study involving 341 bipolar insular stimulations found that 70% produced somatosensory symptoms, while contralateral face and or upper extremity sensations were most common. Distributions were variable when stimulating the insula. This ranged from small, well-circumscribed areas that could be like, oh, I feel that in my tooth, I feel that in a specific joint. It could be combinations of these areas, whether it was contiguous or non-contiguous. It could be your knee and your elbow. It could be your knee and your calf. And it could even be very large areas of the entire body, all from insular stimulation. Vestibular or vertiginous seizures are characterized by the specific illusion of rotary movement of the body or one's surroundings. This is often accompanied by the feeling of nausea, but it should be mentioned that vertigo is an unusual finding in focal seizures. So if some patients are saying they consistently have this vertigo, then you know that you have a rare case there. The localization, however, with this is not very helpful. Seizure onset zone for vertiginous seizures has been found in temporal onset, parietal, insular, and frontal lobes, all reporting as generating these types. However, if you have temporal lobe cases, it's more often found on the dominant side than non-dominant side. So if you're able to hone down your vertiginous seizure to the point of like, well, I think it's the temporal lobe, then you can take it a step further and say, well, it's likely the dominant. Now, visceral sensations, including nausea, dyspepsia, the things Pepto-Bismol treats, hunger, and tend to be common ictal manifestations of visceral seizures. These sensations typically begin in the midline at the level of the stomach and have a rising character, spreading to the chest, throat, head, and face. And I've had a few patients who describe these gustatory sensations with this rise, and very frequently when they get to the sense that, okay, well, it's starting to get to my neck or my throat, that's when it tends to generalize, and their focal seizure can transition into a generalized seizure. And the intensity of these feelings may vary in quality from, yeah, it's a little bit disturbing, to all the way to painful. These have classically been associated with mesial temporal foci, have also been associated with frontal lobe seizures as well. Visceral sensations and sensations of laryngeal constriction have been reported in intracranial EEG studies of the insula. Again, we're having some of those deeper structures of the head and neck being associated with seizures of the insula. And moving on to visual, 85% of patients with occipital lobe epilepsy have seizures that begin with visual hallucinations. These can be elementary hallucinations. I had a patient who described it as he kind of saw the buffering sign from his iPhone constantly, to just undulating shapes, waving patterns. And this is in contrast to complex visual hallucinations, which may take on the form of objects, animals, people, or scenes, and may be familiar or frightening to the patient. Visual illusions, including micropsia, macropsia, metamorphopsia, all the things that you would associate with Alice in Wonderland syndrome, such as the micropsia, macropsia, things shrinking, things growing, metamorphopsia, the distortion of the contours of an object, are associated with occipital lobe seizures, as well as dyschromatopsia, the change of colors of objects. Now, if the patient is reporting elementary visual hallucinations, this most commonly represents activation of the Brodmann areas 17 and 18 of the visual cortex, but have also been reported from temporal, occipital, and anteromedial temporal lobe epilepsies. In contrast to elementary hallucinations, complex hallucinations tend to localize to the visual association cortex of the temporal and parietal lobes. An emotional component is more suggestive of the temporal lobe involvement as well, or temporal lobe onset. Seizure lateralization with both elementary and complex seizures is contralateral to the visual field in which the hallucination appears. However, there is such a thing as a traveling visual phenomenon where the hallucination will travel from one field to the other, and in that instance, the lateralization is less useful. And we've talked a lot about localization, and this is going to be a bit of a shameless plug. Hopefully this talk has been exhaustive rather than exhausting, and it is a conversation that warrants further discussion with each patient. Each clinical scenario and each subcategory of semiology can be further expanded. For further reading on the topic, I would encourage you to look up the papers Seizure Semiology, Localization, and the ILAE 2017 criteria, found in Epilepsy and Behavior, January issue 2022. I can also send this article out to you if you are interested. This information and more expanded for each of these sections can be found in that, as well as a section that I didn't feel I would have time to talk about that goes a little bit beyond the seizure semiology, involving things such as post-ictal nose wipe, ictal spitting, and other ictal activities that aren't as clearly localized or stereotyped based upon stimulation and depth electrode studies. So there were a lot of references involved in putting this together. This is just a few of them. And if there are any questions, I'm happy to discuss them now.
That was a great talk, Grant. Thanks so much for putting it all together with the videos and everything. I know that's time consuming. I'm going to print off your paper now for future reference. But seriously, I know this was a big endeavor, but thank you so much. It was really useful to hear it all kind of articulated and organized so well.
Well, thank you. It took quite a bit, but in that paper, there's a nice summary table as well where you can be like, okay, well, this is what I'm seeing. This is the likely areas, and these are the supporting references. So you can actually go back and say like, oh, well, here's a quick look, and then it expounds upon all those. Yeah, I hope it's helpful to somebody.
Grant, I have one question.
Yes.
Looks like the seizure aura is very similar to migraine aura. So my question, we do more EEGs on migraine patients to make sure it's a migraine or seizure?
I would say, as always, we have to follow our clinical suspicion, because migraine, seizure, and even some stroke symptoms all kind of overlap. We're talking about the central processor of the human body, of the human person. So if you are getting a report of somebody that says, you know, I get this this head pain, this headache, and it's the same way every time, and it's associated with these symptoms, very stereotyped, that would be more suspicious of seizure, and it wouldn't be a bad idea to try and just rule out the potential. But in the same way, if you have somebody coming in with sudden onset aphasia, you're going to want to rule out a stroke first before you proceed to saying like, well, this could potentially be seizure activity. While there are a lot of overlaps, at the end of the day, the best guide is going to be your clinical judgment, I think. I don't think that there's going to be a gold rule where it's like, or a gold standard where it's like every time somebody with a migraine comes in, they should get an EEG as well.
Yeah, especially the sort of called migraine without a headache, just present aura symptoms. I think we have to be careful about that.
Right, such as hemiplegic migraines.
Yeah.
And things like that.
Yeah. Thank you. That's very, very nice presentation.
Thank you, Dr. Wong. All right. If anybody has any further questions, feel free to reach out to me. If you want a copy of the paper, you can drop your email in the chat and I will send it to you.
Good job, Grant.
Yeah, thanks. Appreciate it.
Thank you very much, everyone.